Good morning. My name is Kate Carpenter at the Iowa Healthcare Collaborative, and I want to thank you for joining Webinar 6 of the Swim Towards Stewardship project. Today we have two of the members of our Swim Towards Stewardship project team joining us back today to present. Dr. Castagnini, who's a pediatric infectious disease doc and also the director of antimicrobial stewardship at the Children's Hospital of San Antonio, and Lisa Vitale, who is a nurse clinician for the HAI program at the Iowa Department of Public Health. As we get started today, as always, there's a couple of functions of the Zoom webinar platform that we'd like to remind you of. In the middle of your toolbar, you'll see a chat. Please feel free to click on that button and enter and engage with our presenters today through the chat function. Ask any questions that you might have throughout today's presentation, and we'll be sure to answer those questions. You can use the raise your hand or also the Q&A if you've got a specific question you'd like to type into the queue. A few additional instructions before we get started. This session will be recorded and transcribed. That recording link will be sent out to the Swim Towards Stewardship team leads following the webinar. Additionally, that information will be posted to Hinnovation. So if you're a Hinnovation user, you'll find the recording link, slide deck, and transcription posted there. And without further ado, I do want to recognize and thank our 4 hospitals who are committed to this Swim Towards Stewardship Fishbowl about 6 months ago. We have teams from Virginia Gay Hospital, Keokuk County, Clark County, and Gunderson Palmer Lutheran Hospital, all from the state of Iowa. And I really want to recognize their commitment to this work over the past 6 months. I think you'll see how much progress they've made. And I want to particularly thank the pharmacists at these organizations who stepped up to lead these teams. So sort of to recap where we've been so far, you know, back in late spring, really, of this past year and into early summer, we started promoting this project, and what we were asking for is a small cohort of hospitals who were not as mature in their stewardship program. So we were looking for hospitals that had 4 or less of the core elements in place, but that could kind of procure a letter of commitment from their CEO and also from a team leader who was either going to be a pharmacist or a physician. So the folks that you're seeing in the fishbowl today fell into that category and completed that letter of commitment. Things that we asked for of these hospitals was to participate in each of our 6 program webinars for the team leads, the pharmacists at these facilities to assemble a multidisciplinary team to help progress their work of their stewardship programs. We asked them to participate in a pre and a post survey and to engage in monthly coaching calls and email exchanges with their assigned coach. So these folks have been dedicated to rapid cycle improvement and learning, and we are thrilled actually today to be able to share with you some of the results we've been able to see so far from this group as we've progressed through the past 6 months. As I mentioned, this cohort did complete a pre and post survey. I'd like to go through some of those results. In fact, I'd really love to share them all because they're really great. I wish we had time today, but I wanted to highlight a few. This first question says, to indicate the level in which you understand the 7 core elements. So 0 indicating that they didn't understand well, and 100 meaning they understood them all very well. You can see on the left, the pre-survey response was about at 70%. And here at the post-survey, we've reached 100%. So we have achieved really a solid understanding of the core elements. The next question is to indicate which of the 7 core elements that they currently had in place. So at the beginning of the program, when we started back in June, to let us know which of the 7 they currently had interventions in place for. And you can see on the left-hand side, the only thing everybody had was that drug expertise, and a few hospitals had a few of the other variables. You can see on the right-hand side, as we surveyed this again in the post-survey this month, you can see that many of our hospitals have achieved implementation of almost all of the 7 core elements: leadership commitment, accountability, drug expertise, tracking and reporting. We're at 100% for. And then action is slowly trailing, and education remains our biggest opportunity. The next question is, how is their leadership demonstrated their commitment to their stewardship program? And so we asked if they had certain things in place. Those things were accountability documents, budget plans, infection prevention plans, or a performance improvement plan. Was stewardship a part of their strategic plan at their organization? Do they use, there in the purple you see, using their electronic health record system to help collect stewardship data, or if they had others? And so you can see on the right-hand side, when we surveyed this again this month, the growth we've seen in each of these areas. Next, we asked hospitals if they educated their patients and families as needed regarding the appropriate use of antimicrobial medications, including antibiotics. And this was an eye-opener. You can see in the pre-survey response, we had nobody that was able to respond yes to this question, and even some that were unsure. And here in the post-survey, you can see that we're almost at 70% have moved to a yes response to being able to provide some education to patients and families regarding antimicrobial usage and medications. So this is an excellent leap. The next question relates to the hospital's antimicrobial stewardship program, if they're using multidisciplinary protocols, whether that be policies or procedures or interventions. And we asked them if they did to let us know which they had in place. And so I know that the print is small, but I'll read some of these examples to you. So the first one is antibiotic formulary restrictions. We didn't see a lot of growth there, but the next few down, you can see that we've moved those to 100%. And what those are assessment of the appropriateness of antibiotics for the blue line is community-acquired pneumonia. The next line down, that gold line, is for skin and soft tissue infections. And then that blue or teal line is for appropriateness of antibiotics for urinary tract infections. So excellent growth there. Further down, you'll see that red line that has extended out to 100%, and that's guidelines for antimicrobial use in adults. Great growth there, and the green line indicates a plan for oral antibiotic conversion. So really great growth. I think you can see we made some leaps and bounds as far as implementing policies and procedures and interventions in this area. So big kudos to this cohort for their growth in this area. The next question is, does your facility monitor antibiotic use consumption at either unit or facility-wide level using one or more of the following metrics? And we knew right away when we saw this response that this was an area of opportunity. We had none of the hospitals that were doing any measurement. And so you can see in the post-survey, when we surveyed again, that this is an area we saw a lot of growth in. The measurement of choice that they've moved forward with is days of therapy. So we're thrilled to see some movement in measurement. Another one of the survey results that I didn't include here, but I thought was important to mention, is in the pre and post survey, we asked specifically, are they sharing reports on antibiotic use with their prescribers? And we also saw growth in that area in the post survey that had also reached 100%. So not only were they collecting the data, but they were sharing it with prescribers. So excellent growth here. So I think you can see how this cohort has already propelled quite quickly in achieving some success in different areas of their stewardship program. And with that, I'm going to go ahead and pass it to our presenters from the team today, Dr. Castignini and Lisa, for some new action, some thoughts on education, and things to keep in mind as we continue to progress following this project. Dr. Castignini, it's all yours.
Thank you very much, Kate. Good morning, everyone, and it's nice to talk to you again for this final webinar. First off, the data you just presented, Kate, is remarkable and very encouraging. I feel that this is a statewide effort that, you know, if you have the opportunity to maybe even write it up or present at a conference, it will be very well received. What I wanted to talk to you about in this webinar is some actions going forward, and I like to use the analogy of stewardship being like a tree, and you've all already planted that tree and you've been watering it well and taking care of it. But what's very important is that we get the roots very strong in your institutions. And like I say to my own stewardship program and people learning these projects, is that try to remove the individuals from the equation. And what I mean by that is that people change. There will be changes in leadership. Even pharmacists will be moving to a different job, but the stewardship needs to stay and needs to stay very strong. And for that, what I recommend is usually getting your program established in your institutional committees. So maybe you're already doing this. These are some examples. Of course, not all of them will apply, but depending on the size of the program or the size of the hospital, your antibiotic stewardship, you can create an antibiotic stewardship committee, a standalone, and that's what we have here. We meet quarterly, and we have members of each division join us, and we discuss with pharmacy and microbiology and infection control going forward our new policies, what we've done. We share our data, and we report directly to P&T. And P&T reports, which is Pharmacy and Therapeutics, reports directly to the Medical Executive Committee. So it all goes there, and it's in the minutes, and it's written. And, you know, again, it does not depend specifically on each individual. And of course, we're all working with people, and that's very important. But what I suggest is that this gets in writing in your policies and bylaws. Again, these are just examples. Infection control and prevention can also be a venue that this can be discussed. It can be discussed in P&T. Quality and safety, we present our data in the Quality and Safety Committee as well, and it needs to go up all the way to the Medical Executive Committee so they know that this is ongoing and happening. Again, if you write a policy specifically for your program and you put it in the bylaws, it's very helpful going forward. Next. I recommend that you review your ASP policies at least once a year, or even more than that if that's needed. So it gets changes with new technologies, and we're going to talk about rapid point of care diagnostics in a minute. But as you get new technologies applied in your hospital, these need to go into your policies, and those changes need to be there. The other thing I wanted to mention is that CMS is requiring antibiotic stewardship programs in hospitals, and last but not least, the Joint Commission looks at this closely. We just recently had our survey. The Joint Commission came and visited us, and we had an entire day of their survey dedicated to stewardship and infection control. So we had to present our data, and it came in the report. So and that's very important to keep in mind. The next thing I wanted to talk to you about is rapid point of care diagnostic. And just to put you in context, in September of 2014, a document was drafted to report to the President on combating antibiotic resistance. This was a report that was drafted by a group of experts. And in that report, next slide, you have the table of contents here. And if you keep advancing, Kate, because I'd like to point out number 6 there. It says stewardship of current antibiotics, and that square is intended to point out that rapid point of care diagnostic is part of this document. This document was then followed by a document that was published in June of 2016, next slide, of the Federal Register of the Department of Health and Human Services. As you can see that on the right side of the slide, there's an extract of that document, and I'm going to just read it to you. We are also proposing revisions that will require a hospital to develop and maintain an antibiotic stewardship program as an effective means to improve hospital antibiotic prescribing practices and curb patient risk for possibly deadly C. diff infections, as well as other future and potentially life-threatening antibiotic-resistant infections. So what I wanted to talk to you, and this is just to put you the background and the context on how important rapid diagnostics or rapid point-of-care diagnostic is. Next slide, please. So what are the new diagnostic tools in the horizon? And I'm going to discuss mainly the FDA-approved technologies. There are, of course, a ton of these technologies that are in the pipeline, but I just wanted to focus on the ones that are FDA-approved. Some of these are may also already be implemented in your programs, and I'd like to hear at the end if any of you have these technologies available at your hospitals. But if not, this is a point going forward that you need to advocate for it with your leadership to get these included in your hospitals and part of your stewardship programs. So we're going to briefly discuss blood culture, new rapid point-of-care diagnostic for blood cultures. There's two main platforms that are used. The blood culture identification, that's the BCID. That's by a company called BioFire, and the other one is VeriGene. The VeriGene is also a new technology. We have that one here. And by the way, I do not work for any of these companies. I don't favor one or the other. I'm just going to go briefly over both of them. Then there's some platforms for CSF, some for respiratory panels, and some for stool PCRs. These are all molecular-based technologies, and we'll talk briefly about them. Next, please. So this is just the microbiology process for blood cultures. When you get a sample from a patient, say that you're suspecting bacteremia or sepsis, you put it on incubation in your instrument. We have BACTEC here, but you may have different instruments, and then it takes some hours to get that blood culture positive. After it's positive, it is placed on an agar, and it's again in incubation for another 24 hours. And then after at least 24 to 36 hours, you will have ID and susceptibilities back. What these rapid point-of-care diagnostics is trying to do is give you an answer in about 2 to 4 hours after the blood culture has been reported as positive. Next, please. And you see there that RDT, or rapid diagnostic testing, will be ready in 2 or 4 hours for you, so you can act on those results rapidly. And I'll have a few examples coming down in a few minutes. These are the two instruments I was talking about before. The film array blood culture identification has 27 targets. If you advance one more, Kate, please. So you have there the number of targets that this instrument has. And you can see all the lists there, the ones that are included, different group of gram-positive and gram-negative bacteria. Most of the organisms you will be looking for are here in both instruments. The VeriGene divides their instruments in two different groups, the gram-positive blood culture and the gram-negative blood culture. Each of them have different performances and different amount of targets. As you can see there, 15 for the gram-positive and 14 for the gram-negative. And just to give you an example, next please, this is a report of a patient of mine. This is a 10-year-old child that came into the ER complaining of back pain and had fever for 3 days. And he, in the emergency room, had to be transported emergently to the ICU because he became hypotensive and in septic shock. Blood cultures were obtained, and this report came about 12 hours after the blood culture was obtained. And it was about 2 hours after the blood culture was reported positive. And we knew, as you can see in the report, Staphylococcus species DNA was detected, and Staphylococcus aureus DNA was detected, and the MEC-A, which is that gives the resistance marker. So you can also know if this is an MRSA or MSSA bacteria in about 2 hours after the blood culture is reported positive. So we were able to, this patient, of course, was starting on 3 different antibiotics. We were able to tailor antibiotic therapy and de-escalate faster than otherwise we would have. The next one is another example as well. This is just to show you the gram-negative panel for the very gene that we use. In this particular example I wanted to bring is that it was a Serratia marcescens that grew, which is not part of the panel. So you have to be aware that some bacteria may not be detected. And we'll talk about that in the limitations in a minute. The third example I have is a patient that I'm actually caring for now. She's currently in our ICU, and she came from the clinic. She has neuroblastoma, so she has an oncologic diagnosis. And she had fever and neutropenia and was from the clinic admitted to the floor. And that evening she crashed and had an event and had CPR for an hour, and blood cultures were obtained. And the report was, again, 2 hours later, we knew that Enterobacter was growing in her blood. And not only it gives you the bacteria, but it also gives you the resistance markers, and they're listed there. So the provider can act on this report fast and provide with the right antibiotic to this patient. I'm happy to say that she recovered fine. She was extubated yesterday, and she's been communicating fine since then. Next slide, please. So there's studies looking at the performance of these platforms, and I just bring one for your attention. This was a study mainly from Mayo Clinic, looking at these PCR technologies in blood culture, specifically the very gene in this particular study. This was a randomized trial. The outcomes are listed there, and as you can see, the p-value was not significant for all the things they looked at: length of stay, 30-day mortality, 30-day readmission, adverse reactions, blood culture clearance in 3 days, and C. diff incidence. So that was discouraging in a way, but next slide, please. They also found that in this graph here, you have time in 12-hour increments. 0 is the time that the blood culture is reported, and they compared the rapid multiplex PCR with controls, with the presence or absence of stewardship program in that institution. The red squares is when the bacteria is identified. So as you can see, when you have these PCR panels in place, you have identification within the first 2 to 3 hours, as opposed to almost 24 hours in the control group. The other important finding was that in the rapid multiplex PCR group with stewardship, they were able to de-escalate therapy at 18 hours on average, as opposed to the controls, which is past the 36 hours, which is the first line there at the top. So in essence, what these authors concluded is that while most of the long-term outcomes like length of stay or mortality or toxicity were not affected, they were able to de-escalate therapy in a faster manner when they have these technologies in place. So the next slide, please. So some of the benefits of these rapid diagnostic technologies is that the turnaround time is less than 3 hours for both platforms. The blood culture identification from BioFire is 2.5 hour, and the very gene is a 2-hour turnaround time, and hands-on time is less than 10 minutes. It's very simple to use, and it just requires that you have the platform or the instrument in your facility. Results in antibiotic changes benefit the patient and your stewardship program. So you can target the therapy, you can optimize the therapy. On those 3 patients I just described to you, we were able to apply these concepts very nicely. We were able to de-escalate therapy and target the therapy for the organisms that were growing. These platforms have very high sensitivity, so that means there are very few false negatives. So that's very important to point out. Next slide, please. However, there's, of course, some limitations. This is an add-on test. This is not a replacement method. In other words, if you get these platforms in your, or these instruments in your institutions, you will still have to go through the regular process because that's the current standard. So these will not replace the current methodologies, which means it adds cost because the instrument you're bringing into your institution will not be replacing anything. Add cost from that standpoint. However, overall cost benefit may be observed because you're de-escalating faster, because you're changing your antibiotics to a presumably low-cost option, and there might be cost savings there. Some pathogens may not be identified, as the example I gave on the second patient I showed. That patient grew serratia in blood, and that was not identified by the very gene. So we were stuck with 48 hours until we had the identification and susceptibilities back. There is low specificity. Unfortunately, there's some organisms that may be misidentified or identified, and the patient is actually not infected, and these are contaminants and that kind of situation. Mixed infections, when you have more than one pathogen, sometimes the second pathogen is not identified. And the resistant detection is limited because, of course, we have a limited panel. It will tell you if it's MRSA or not, but it doesn't tell you anything else. It may tell you if it has an ESBL-producing bacteria, that means it's a highly resistant bacteria, but it does not tell you if, say, for example, cefepime will be effective. So those are some limitations to take into consideration. The next slide, this is a study looking at how well it identified the organisms in comparison with the PCR methodology and the conventional methods. And it was 100% accurate in most of the organisms, and the only organism that was misidentified was the coagulase negative staphylococcal, or Staphylococcus epidermidis, was misidentified as being a coagulase negative staph of a different origin. So I just wanted to show you that everything else had 100% match, albeit there were not the N was not that high. Other rapid diagnostic technologies. This is the BioFire film array for the meningitis encephalitis panel. When you get CSF studies, you can put this in the instrument, and you will have all 14 targets in about an hour. This is extremely helpful. We get the organisms on almost all our patients with meningitis or encephalitis really fast, and you can act on things. Patients may be on antibiotics, and it grows or it detects an enterovirus, so you can de-escalate therapy and stop antibiotics if the case, if it's appropriate. So these are extremely helpful. It took us a while to get this in our hospital because we didn't have enough data to show it to our leadership that this will be a cost-saving instrument. However, we were able to get it about 2 or 3 years ago, and we've been using it successfully since. The next one is the gastrointestinal panel. These, for example, these we do not use in our institution. I just bring this to your attention so you know it's out there. The problem with that I find with this specific one is that it almost always detects something, and sometimes you don't know what to do with that result. I get calls frequently from physicians or providers in the community asking, "Yeah, this patient had diarrhea. Is detecting these E. coli, and the patient's now better. I didn't do anything. What should I do with this?" And that happens a lot. So I would reserve this panel to immune-compromised patients, patients with chronic diarrhea or chronic gastrointestinal problems. In that setting, it might be useful. So we currently have it as a send-out test and not in-house testing. And last but not least is the film array or respiratory panel. These had to be, this was the first panel we introduced in our hospital about maybe 8 or 9 years ago. It's been in use. And it's helpful because it includes influenza, and it includes also Bordetella pertussis, which sometimes we have outbreaks and we like to check those. And it gives, most of the time, is helpful because it gives an answer. So you don't know what may be going on with the patient. The patient has respiratory symptoms. The patient is admitted to the hospital, and you want to know what may be happening with this patient if the fever is related to viruses or bacteria. And this is a helpful panel for that. The other helpful, or the other benefit of this panel is you can cohort patients and put them on isolation as appropriate. If you grow, RSV, or if you detect RSV, I shouldn't say grow, this is a PCR panel. So if you detect RSV, you can put the patients on the appropriate precautions. And that's I think what I wanted to bring to you today. Of course, I'll stay here in case there are any questions later on, and I will hand the mic to Lisa now. Thank you.
So now we're going to give the mic to Lisa Vitelli at the Iowa Department of Public Health. As we talked about at the beginning of the session, the education element is one that we haven't seen as much growth in that area, and we haven't touched on as strongly up to today. So we want to spend just a little bit of time touching on how you can do ongoing education. Thanks, Lisa.
Hello, everyone. I'm going to talk a little bit about ongoing education. So ongoing education and training opportunities are key aspects to an effective antibiotic stewardship program. So education really should be available to nurses, healthcare providers, and pharmacists. I've included some topics that you may want to include in your ongoing education. So causes and trends of antibiotic resistance, optimal prescribing guidance, maybe including some case studies, and involving your patients in the education piece for the stewardship, maybe with patient narratives or stories. Next slide. So you want to incorporate quarterly updates on antibiotic stewardship and resistance into communication tools. Some examples of communication tools would be your website, your intranet, newsletters, and possibly having in-person presentations or webinars. Incorporate the core elements into orientation for new medical staff. And you could also participate in the World Antibiotic Awareness Week, which will be in November of 2019. Next slide. So patient education tools and resources. Patient and caregiver education really plays a vital role in achieving appropriate antibiotic use. So we recommend that you develop patient education that includes information about the antibiotics. There's a really great website. It's called Choosing Wisely. They have really good patient-friendly resources that you could provide to them. Some examples are taking medicine safely, antibiotic treatment in the hospital, antibiotics for people with catheters. There's a wide variety of patient-friendly resources on the site, so I thought I would include that. Next slide. There's also the CDC training for antibiotic stewardship for healthcare professionals, and basically it's an interactive web-based activity for healthcare professionals. The goals are to optimize antibiotic use, combat antibiotic resistance, improve healthcare quality, and improve patient outcomes. It's a blended series of education, and it does offer continuing education. Next slide. So for tracking and reporting, monitoring antibiotic resistance and prescribing patterns is crucial to identifying opportunities for improvement. The collection of data allows organizations to assess, monitor, and improve prescribing practices. So keep looking for solutions. Some ways would be to audit on a quarterly basis to identify improvement, maybe to choose a syndrome to track and report when data suggests a large amount of antibiotic use and resistance, or you can identify the top pathogen relevant to your organization and monitor at least one of those organisms.
Thanks so much, Lisa, for helping infuse that information into this final webinar. At this time, before we round robin with the hospitals and our fishbowl and get some feedback on the project directly from them, I do want to open up the mic and ask our team leads if they have any questions for Dr. Castagnini or for Lisa on content presented today. If you've got a question, I don't see any through the chat, but go ahead and unmute. Okay, excellent. With and not hearing any questions, we'll go ahead and start our fishbowl sharing. As we mentioned, these hospitals each made commitments to this project early in the summer, and as you can see from the information shared today, they've taken that information and really run with it. So we'd like to give them each an opportunity to share for a few minutes each. Certainly, they don't have to hit on all these, but they're prepared with some of these talking points. And so we'd like to give them an opportunity to do that now. We're going to turn first to Lisa Sandy. Lisa, are you on the line? Or sorry, Jill, are you able to hear us? Jill Sandy? Let me see if I can help unmute you, Jill. Well, we get that coordinated for Jill. Sarah Barnes, are you on the line? You may have to unmute your line. Dan LaGrange, I know that you're connected into audio.
Yes, can you hear me?
We can. Go ahead.
Yeah, so I guess as far as our accomplishments that we worked on, it was more about getting a plan together and determining what everybody already did, which was kind of our starting point. Then we had, in the middle, we spent a lot of time getting our antibiogram started and tailored to our needs. That was spearheaded by our nurse manager that really took that and ran with it and did a nice job of getting a good antibiogram. We also implemented a process for patient education, which we hadn't really been doing, to get the patients more on board with stewardship as opposed to just not really including them in the process. We also developed a plan for pharmacy to document stewardship practices, which included kind of the 48-hour timeout and then monitoring for appropriateness and de-escalation. And then last, we've been working on our policy and getting that clarified so that, as Dr. Castanighi said, we have some sort of accountability and it's more positions instead of people. So I think that was a good point that he made.
Excellent. Thanks for sharing, Dan. Would you be able to comment at all on maybe some of the barriers or challenges you guys encountered that maybe you hadn't anticipated?
Yes, the time commitment was a big thing, where getting, being a fairly small hospital, getting people here on the same days and getting everybody in the same room, and then trying to make a plan for that going forward where we can continue the work. That was something that we didn't really anticipate.
Yeah, I know that we have heard that from others as well, you know, and I know Dr. Castiglini has specifically talked to just protected time, especially for the pharmacist or your program leader. It really does take dedicated time, and so I appreciate everybody sort of overcoming that barrier as we progress through this project. And we certainly know that it is a challenge. Michelle, are you on the line?
Can you hear me?
Yes, we can hear you. Go ahead.
Awesome. Well, so this is Michelle Evink. I'm with the whole team from Clark County Hospital. And as a critical access hospital, our path was a little bit different than I think we anticipated. One of the things that we ran into is our length of stay is so very short that our approach has to be different from larger facilities, because if our patients are staying here 2 days, then by nature, a lot of that de-escalation is happening. And our patient population for the last 6 months particularly hasn't been really full of inpatients that had a lot of long-term antibiotics or broad-spectrum antibiotics. But coming into this, we were already monitoring for appropriateness. The pharmacists round on patients. We try and do our education then, although that's always, there's more opportunity there. And during this, our major accomplishments have included getting our local antibiogram established. We'd been getting an antibiogram, but not really understanding that our results were part of the pooled information. And so this has given us a little bit more specific information, though our N is very low. And so we'll continue to work on making sure that that's relevant data for us. And it also gave us an opportunity to look at where antibiotics are being used, where our cultures are coming from, and the information that we're getting from that culture information, identifying that we have a community, the community that's producing, coming in with infections, but also we have a nursing home that has, we believe, its own kind of biosphere that we need to make sure that we're accounting for, because it feels like that is very much its own situation. But all of that we're looking at with an eye toward providing appropriate guidance. Our biggest opportunities that we've identified include reducing the length of therapy to the most appropriate length, and we continue to work on that. Our hospitalist has been engaged in that. We're still working on that. Working on putting together education to staff, providers, particularly our ER physicians, our patients and our families, and routing of information to maximize the pharmacist's involvement, because we don't have a pharmacist here all 7 days a week. We don't have, so how do we make sure that the information gets to the right person? We have pharmacist coverage, they're just not on site. All of this, though, we're attempting to aim at creating and maintaining a culture of stewardship that sees all antibiotic use as an opportunity to maximize effectiveness while minimizing exposure to medications. And I think that we'll continue to work on that or toward that goal with all of our different efforts. One of the big accomplishments for us is making sure that it was on people's yearly goals. Our fiscal year ends in June, and making sure that antibiotic stewardship was on people's goals, because our goals really drive the distribution of our time and our energy. And so this is something that we'll continue to work on through the end of our fiscal year, especially with more force, and then make sure that we have a plan that continues after that.
Excellent, Michelle. Thank you so much for sharing. I know that Sarah is typing in some information. We're having trouble connecting her audio. She can hear us, but we can't hear her. And Sarah's just mentioning from her team's perspective, they also, similar to her colleagues on the line, they'd looked at the antibiogram, but they have such a small N when compared to the larger health systems. But they did compare theirs to a larger health system's antibiogram. They decided for better, larger data, they'd use the health system antibiogram for now. Let me thumb down and see if she'd entered any more. She's saying that they don't have sufficient information for their emergency providers, and in the future they'll be updating or mainly creating a new order set to help guide therapy there. And Jill's on the line as well, but we're having trouble getting their audio hooked in. Dr. Castagnini or Lisa, do you want to comment just on what you've heard so far from the group?
Well, I can make a few comments. I think the challenges and the barriers that the groups have been seeing are the typical problems and challenges that everybody faces. So what I would say is that in 6 months you've accomplished more than I've seen in other programs. So this is remarkable. I think I have a sense of you're all very committed in continuing this and getting it stronger. So that kudos to everyone, and I think this is phenomenal. The challenges you have challenges now, and the new challenges coming up. I'm sure there will be new ones, but you know, I always try to remember back to the basics. Is that what's doing what's best for the patient is what takes us to work every morning, I guess. But so I wanted to congratulate everyone on their accomplishments.
We have information from Jill Sandy coming in through the chat, and she's just adding that they did obtain a new machine to do procalcitonin, and all their providers are on board with ordering blood cultures and procalcitonin tests before and after starting antibiotics. So that has been a positive action from their facility recently. They are starting to put out some education programs for their providers there at their facility, Jill is sharing. So I think really just a tremendous amount of positive motion in each of the core element areas. I'll say just in closing, I appreciate everybody's commitment and for them sharing some of their work today. Our team will continue to be available to you. There's a tremendous amount of resources and support available through the Iowa Department of Public Health and here at the Iowa Healthcare Collaborative, specifically through the Compass HIIN. I know that this is an area that the Iowa Hospital Association is very dedicated to. And so if there's specific things, tools, resources, support, education you could use assistance with into the next year, please do bring those to us. We'll be looking for your feedback, and we'll be checking in with you periodically next year to see how things are progressing in each of your facilities. I want to extend one last thank you to our project team who's helped support this project and provide individual coaching for each of the hospitals in this cohort. We thank you for your dedication to this effort. Thank you again for being a part of the Swim Towards Stewardship project here at the Compass HIIN. We hope you all have a Merry Christmas and a Happy Holiday. Thank you.